Welcome to The Explainer. Today, we're diving into something we see all the time, right? A patient comes to the counter and says, "I just can't sleep." We're going to go way beyond the basics and really get into the clinical pearls you need to handle these conversations like a pro. So why are we talking about this? Well, it all comes down to this number, 22%. Think about that for a second. Nearly 1 out of every 4 people in the general population is dealing with insomnia symptoms. That means a huge portion of the patients you see every single day could be struggling with this. It's a massive issue.
But just saying I can't sleep isn't a diagnosis. To really help, we need to know the clinical definition. According to the DSM-5, we're looking for something specific, a persistent problem. We're talking at least 3 nights a week for at least 3 months that's causing real problems in their daily life. That's the bar for insomnia disorder.
Okay, so when that patient shows up with a sleep complaint, our first job as clinicians is to take a step back. Before we even think about solutions, we've got to understand the whole clinical picture.
And this right here, this is the most important question you can ask right out of the gate. Are we actually dealing with primary insomnia, or is something else hiding in the background just pretending to be insomnia? Seriously, the entire game plan hinges on getting this right.
So, we have to play detective for a minute. Before we land on an insomnia diagnosis, we've got to rule out these common mimics. You have to screen for things like restless leg syndrome or maybe even sleep apnea. Each one of these needs a totally different approach, so we can't just lump them all together.
All right, let's get into patient assessment, because this is where a pharmacist's expertise is just crucial. A huge part of our job is to put on that pharmacology hat and figure out if a medication might be the real villain here.
A solid medication history is, and I mean this, absolutely non-negotiable. You have to look for all the usual suspects, right? From their prescribed SSRIs and corticosteroids to that OTC decongestant they grabbed last week. And this is a big one, our review has to include stuff they might not even think of as medicine. That nightly glass of wine or their smoking habit. Yeah, those could be the hidden culprits messing up their sleep. Okay, so let's say we've confirmed it's insomnia. What's the #1 first-line recommendation? For a lot of patients who are just expecting a pill, this can be a real surprise, but the evidence is crystal clear. We start with behavior, not pills.
If you take only one thing away from this whole explainer, let it be this. Cognitive behavioral therapy for insomnia, or CBTI, is the primary first-line treatment. That's what the guidelines say for all patients with chronic insomnia. Full stop.
And look, this isn't just a casual suggestion. This is backed by some powerful evidence. Study after study shows that CBTI works better than medication. And here's the kicker. The results last. It gives patients skills for life instead of just patching the problem for a single night. But just saying try CBTI can sound a little vague, right? So we can make it real for them. We can break down just one part of it, like stimulus control therapy. These are simple, doable steps. The whole point is to break that anxious cycle and retrain the brain to associate the bed with one thing, sleep. Now, this is a really important distinction we need to help patients understand. Sleep hygiene, the usual advice like avoid caffeine or keep the room cool. That's all helpful stuff, but it's not enough to fix the problem on its own. CBTI, on the other hand, is a structured, comprehensive therapy that is proven to work. It's the difference between a helpful hint and a gold standard treatment. Of course, you know it's coming. The patient is inevitably going to ask about over-the-counter options. This is our bread and butter, and it means we need to have a really careful, evidence-based conversation about what actually works and what the risks are. Okay, so here's the quick and dirty on the big 3. For diphenhydramine, the evidence is pretty limited, but the anticholinergic risks are high, especially in older folks. For valerian, the evidence is frankly weak and inconsistent. And for melatonin, the benefit is modest, pretty small compared to placebo, though there might be a small place for a specific formulation in patients over 55.
Let's just double-click on diphenhydramine for a second. According to the Beers criteria, this is a flat-out avoid in patients 65 and older. Why? Because of its high anticholinergic burden. We're talking about risks of confusion, falls, cognitive issues. It's a major safety concern.
And if you need numbers to really drive that point home, look at this. For sedative hypnotics in older adults, the number needed to treat is 13. You have to give the drug to 13 people for just 1 to get any benefit. But the number needed to harm, it's only 6. That is a terrible trade-off, and it's a risk we just can't ignore. All right, finally, let's talk about our ongoing role. Because our job doesn't stop after that first recommendation, does it? We are in the perfect spot to monitor a patient's therapy, whether it's behavioral or a medication, to make sure it's actually working and, more importantly, that it's safe.
So when a patient does end up starting a medication, these counseling points are non-negotiable. We always start by reminding them about the benefits of the behavioral stuff. But if a drug is on board, we have to give clear warnings about driving, about mixing with alcohol, and about having a plan to eventually stop the medication. It's all about safety and managing expectations.
And that brings me to one last, kind of provocative thought to leave you with. Our expertise is in managing medications, and that includes both starting and stopping them. So let's ask ourselves, are we championing deprescribing for these high-risk sleep aids as passionately as we dispense them, especially for our most vulnerable patients? That's a huge question for the future of our practice.